I would like to welcome all of you to this special symposium on transforming health and social care system to provide integrated care for the low and middle income countries. My name is Dr. Suwaji Good. I'm from the WHO Southeast Asia Regional Office. I'm a regional advisor for social determinants of health and health promotion. I have also my colleagues joining us online from the regional office and WHO headquarters in Geneva. These sessions will be participated both online and on-site. We have Dr. Nina Reiner, our Director of Family, Genders, and Life Course Approach, Department of Universal Health Coverage and Life Course Approach of the WHO Southeast Asia Regional Office. We have together also Dr. Yuka Sumi, our medical officer in charge of aging, health, mental health, newborn child and adolescent health at the Universal Health Coverage of the Life Course at the WHO headquarters in Geneva. You're going to be hearing a global perspective, regional perspective, and then come to the country experiences. We have great speakers from India, Indonesia, Nepal, and Sri Lanka for this session. I hope you will enjoy these sessions together. Before the presentation, I would like to invite Dr. Nina Reiner, our Director of Family, Genders, and Life Course Approach of the WHO Southeast Asia Regional Office, to say a few words to open these sessions. Yes, ma'am, please.
Thank you very much, Dr. Suvaji, Dr. Yuka, Dr. Amrita, and all the esteemed speakers, which is led by and coordinated by Dr. Arvind Mathur. So I'd like to, first of all, welcome you to this webinar and thank International Federation of Aging, especially Dr. Jane Barrett and her wonderful team who has been able to pull this symposium on integrated care of older people together. I'm really impressed, given the short period of time. I think this has been done very well. I think we can't see the audience, we can't see the speakers, but I'm sure that you have excellent, I think now we can see them. We have excellent, participation from everyone. If these kind of conferences, are the best forum to share experiences. As you know, I think I don't need to go through the details related to how WHO defines healthy aging as the process of developing and maintaining the functional ability that enables well-being in older age. And optimizing functional capacity is a key to healthy aging. So we are talking of healthy aging and not disease during the older, elderly or older people. WHO's integrated care of older people approach focuses on optimizing intrinsic capacity and functional ability throughout the healthcare system as the key to healthy aging and supports the diverse needs of elderly people throughout the continuum of care. Key operational concept of ICOPE is to shifting focus from detecting diseases in one point in time and treating in fragmented ways to assessing diverse needs comprehensively and providing care as a continuous trajectory. So it's more individual and personalized approach, and it's an approach. So, but what is the burden of aging? I won't say burden at all because we all are in the same age group. I'll go say the magnitude, and the population is increasing. And you'll be hearing that from Dr. Yuka as well as from me, that how aging population is going to be multiplying, and the trajectory is going up in most of the countries. But then when we talk of integrated care of older people as an approach, I'm very, many countries in our region have started it, adapted it. But then I see that there are issues related to health systems which need to be addressed. And the first and foremost is addressing the issue of insufficient number of trained human resource and appropriate health facilities, especially to take care of emerging needs, emerging geriatric and gerontology needs of the older people, which has been a major challenge. We have people who are healthcare providers who are already overburdened with many things which they are doing. But aging is one additional component where they need time and skills to be able to assess the intrinsic capacity and uh, follow the pathways of management as well. I think guided by the regional framework, which was developed in 2018, where we kept the focus on universal health coverage. We also, that's the time and the decade of healthy aging components have also been included in the regional framework. We see that 2020, the regional expert panel was constituted by the regional director, and it's an advisory group to the regional director under the leadership of this expert panel, and many of the members are going to be the presenters as well. We have been able to really take ICOPE approach forward in a big way. So this forum, this symposium is providing us an opportunity to share the progress and the learnings made from ICOPE implementation in the region and global community working to improve quality of life of current and future generation of older people. And believe in me, all of us who are sitting here need it either now or some of you will need it in the near future. So I hope that these deliberations would help policymakers and the healthcare workforce to support, design, and deliver of improved integrated person-centered care of older people. I'm again very grateful to Dr. Jane Barrett, IFA, for organizing this conference in our region, which is one of the member states of our region, Thailand, and the Ministry of Health, who has really provided support to host this. I'm very grateful to our colleague, Dr. Yuka, who I always call her the mother of ICOPE. Ever since ICOPE started, she has been there and she has led the important work, and we are very blessed to have her present the global scenario and global progress. So I'm very sure that the participants and the presenters, especially from different countries of our member states, it's Southeast Asia region focused. So you will hear that how much progress has been made in our region related to ICOPE. So I wish you all the best and a pleasant stay in Bangkok and enjoy the hospitality. With these words, I'll hand it over to Dr. Sobaji. Thank you very much.
Thank you very much, Dr. Nina. And also, in fact, I have to say Eid Mubarak for many colleagues who are also celebrating Eid today. It's our holiday, but we are working. So we show the commitment of why we are here for the betterment of the people. So without further ado, I also have Dr. Amrita online as my co-moderators in these sessions. The first set of the speakers will be focusing on the learning from pilot and implementations of globally, and the progress and challenge in Southeast Asia, and also the experience on the capacity building from the ICOPE trainer in Southeast Asia region. We have Dr. Yuka Sumi online. Dr. Yuka Sumi, as many of you have learned about her experiences, she's the mother of ICOPE. She was the one who involved in developing the ICOPE and publications of the ICOPE. She was a associate professor in the Department of Emergency and Critical Care Medicine and the Faculty of Gerontology in Juntendo University in Japan. She also was trained as an MD from Kyoto University of Medicine and PhD from Osaka University and MPH from London School of Hygiene and Tropical Medicines. She also is a secretariat of the WHO Clinical Consortium on Healthy Aging. So I will be very pleased to introduce you and let her take us forward on the learning of these ICOPE pilot and implementations globally. The floor is yours, Dr. Yuka.
Thank you so much, Dr. Subaji, and thank you for having me, Dr. Nina, and then thank you for hosting this symposium. I would like to thank Jane Barrett and the IFA team. So in this symposium, probably many of you know already what the ICOPE is about, but just step back where we started and then to go to the global implementation, I'm happy to share with you and also learn from the SEARO experience. As Dr. Nina said, healthy aging has been defined by WHO as a process of developing and maintaining the functional ability that enables well-being in older age. And the functional ability is combination of the intrinsic capacity, so everything under the skin of the individual and the environment the person lives in, and how people interact with their environment. Intrinsic capacity is a composite of all the physical and mental capacity of an individual. As you can see, environment includes not only the housing or transport or the bigger environment, but include assistive technologies and the social facilities. So in the different factors. When people age, we age, our intrinsic capacity tends to decline, and the speed of decline is very different between individuals. As you can see in the photograph that the older person may have a hearing loss, which is her intrinsic capacity, but by providing hearing aids, that is environment, she can hear and she can communicate with the friends and the family, which is her functional ability. In another photo, you can see that the older person might have a mobility loss, which is her intrinsic capacity or his intrinsic capacity. By providing walkers and a safe road, actually he can go shopping, or he can see his family by himself walking. So that is functional ability. So as a public health framework, it's really important to work on both intrinsic capacity and providing good environment so that we can facilitate the functional ability. As you can think about, when you think about older people, there is a bit of ageism aspect that the older people is very different that we need to recognize. There is an older person with 80 years old who can have a full physical and mental capacities similar to many younger people. Or others in the 60s or 50s who has a significant decline of physical and mental capacities requires assistance from the other persons. So the main message is there is no typical older person, which means the care should be personalized and then accustomed to their diverse needs, health and social care needs. So probably in this conference, you already have heard a lot of times about UN Decade of Healthy Aging, and that is global collaboration that will bring together diverse sectors and stakeholders to improve the lives of older people, their families, and the communities in where they live. So the ICOPE is more addressed to one of the action areas, which is deliver person-centered integrated care and primary health services responsive to older people. As you can easily imagine, older people, would like to have a healthcare access where they live. So this is important to promote aging in place, and health and social care services are available and accessible and acceptable for older people close to where they live in the community. That's why we are trying to strengthen the primary healthcare services. So primary healthcare is considered as a cornerstone of sustainable health systems for the achievement of universal health coverage and the sustainable development goals. Achieving UHC, which is universal health coverage, is one of the targets the nations of the world set when adopting the Sustainable Development Goals in 2015. UHC means that all individuals and communities, including older people, receive the health services, quality health services they need without suffering financial hardship. It includes a full spectrum of the essential quality health services, from health promotion to prevention, treatment, rehabilitation, and palliative care, and long-term care across the life course. The vision of primary health care is a whole society approach to health that equitably maximizes the distribution of health and well-being. And recently, we state that around 19% of essential health services can be delivered through the primary health care. We acknowledge that the importance of the referral, importance of the specialized care, but starting point would be the primary health care. So integrated care for older people reflects a continuum of care that will help to reorient health and social services towards a more person-centered and coordinated model of care that supports optimizing intrinsic capacity and functional ability for older people. Since 2017, we have, at WHO, have developed the ICOPE approach and set of implementation tools. And these ICOPE tools aim to support policymakers, health and care workers, and the communities to ensure person-centered care that addresses the diverse needs of older people. As you can see in the figure in the ICOPE implementation framework, at the micro level at the center, older person is the center. So we need to think about what older person wants and what the needs of older person. And then second is service level. We need to really orient service towards community-based care, engage and empower older person and the communities, and support the coordination of services delivered by multidisciplinary providers. It's easy to say, but difficult to be done. But I'm sure we will hear about a lot of experience from SEARO countries after our conversation, our presentation. This is a kind of example, Casey Brown example. She is 75 years old woman with hypertension. Red line represents intrinsic capacity and blue line represents functional ability. On the bottom of the graph, it shows the different health services. Yellow square represent promotion and prevention of decline in intrinsic capacity. This should be available throughout the life. Management of underlying health conditions. In her case, that will be hypertension, should be available in any case. And the care coordination and social support. As you can see with the four numbers, 1 pneumonia, 2 hip fracture, 3 cognitive decline, 4 pneumonia, delirium, dementia. This can happen for everyone. And every time there is any acute condition happens, intrinsic capacity tends to decline. But we really want to promote to maintain intrinsic capacity, providing ICOPE interventions, providing good environment. So as you can see at the bottom, it is a green font. If there is a pneumonia, but still there is intrinsic capacity to be promoted, we can provide multimodal exercise, nutrition, cognitive stimulation. If she has a hip fracture on the second part, we can provide walking aid, rehabilitation. And then if the older person has a cognitive decline as a third episode, home modification might be required. And if that she has a significant loss of capacity and that requires more assistance from the other person, assistive care, caregiver support, and palliative care might be more important for her. The point here is continuum care. So throughout the life course in the second half of life, we really want to adapt the care based on their needs and then monitor the trajectory of intrinsic capacity on the functional ability, optimize her or his personalized care plan So this is the evidence-based intervention we provided in ICOPE guideline that include multimodal exercise, dietary advice, and oral supplemental nutrition if available, routine screening for visual impairment, screening hearing and offer hearing aids. I know that there is a hearing session happening right now in IFA conference. So hearing is one of the really important aspects of the intrinsic capacity, and cognitive stimulation and psychological interventions. Besides this, we have a recommendation for the urinary incontinence, preventing falls, and supporting caregivers. This is really important to address these intrinsic capacity and different aspects simultaneously, if possible, because the reason behind is all the intrinsic capacity decline interact with each other. Malnutrition affect mobility, hearing loss might affect cognitive decline affect the depressive symptoms. So it's really important to address their intrinsic capacity in a holistic way. Probably since you do the ICOPE training and the implementation, you know that all the ICOPE screening tool. And the ICOPE screening tool has been really widely spread and then well accepted. The reason is it's easy to do. So without not too much training, anybody, including volunteers, can do the screening in the community, at home, everywhere you need, and where older person lives. And that is very systematic approach to address the intrinsic capacity. So in the ICOPE handbook, we provide standardized care pathway, starting with screening, assessment, care plan, and follow-up. The objective is to maximize intrinsic capacity and functional ability. And then understanding and respecting values and preferences and goals as the most important things. That's the person-centered care. And then when we do the assessment, that's really important to address the intrinsic capacity, underlying diseases. So it should integrate NCD management, any underlying diseases, and social and physical environment, including assistive technology. And the intervention can be provided at home, at the community. And this is really important to develop the person-centered goal with older person, not just the provider's perspective, but with older person. This can be that, I want to go to the wedding with my grandchildren in 3 months, or I want to continue to do the singing with my friends. So that is the person-centered goal. And we really highlight the importance of the multidisciplinary team. ICOPE should be implemented with the different disciplines, not only about physicians, nurses, pharmacists, physiotherapists, and nutritionists, and different cadres can facilitate the ICOPE approach. And that include community healthcare workers and volunteers in the community. And then even though we are really focusing on the primary health care, if available, we need to ensure the referral pathway and monitoring of the care plan to the specialized care. And then at the last but not the least, engage community and support caregivers. The caregiver's role is very important for older people, for those who have significant loss of capacities. So in 2022, we did publish the findings from the ready phase, learning from the different countries and different cadres. So this is a survey we conducted for the 260 health and care workers with different disciplines from 29 countries, asking what will be the enablers to do the ICOPE care pathway in clinical and community settings in your country. 38% was medical doctor, 20% nurse, and then other disciplines, social care workers, occupational therapists, physiotherapists answered this survey. As you can see that most of the things they highlighted as enablers is local network among multidisciplinary stakeholders and the proactive engagement of older people and their caregivers. Unless older person think ICOPE approach is good, and then this actually helped my health and well-being, ICOPE will not be implemented and then scale up. So this is really important in terms of public awareness, and then have a conversation with the older person so that they can understand what is intrinsic capacity, what we can do about it, including older person. So this is the barriers. Of course, this, intrinsic capacity concept is very new. That was in World Health World Report was 2015, ICOPE guideline 2017, and implementation to the 2019. So right before the COVID. So, when as a clinician, you get to use to the usual clinical practice, and that's already busy enough. So when we are trying to integrate ICOPE approach in the usual clinical practice. So barriers include lack of workforce capacity in terms of the available staff and time, skills, and knowledge. And then lack of infrastructure and system to provide integrated health and social care. Because ICOPE is not only about healthcare, but the social care and support, the infrastructure aspect is very important, including data management, because most of the time medical record and the social care record is separate. But we really encourage to have a kind of integrated platform so that they can exchange the data and they can exchange the care plan discussed together as a team. This is a snapshot of the ICOPE global implementation pilot and interest. I'm not expecting to read all the countries' names. In that report, we included 4 case studies, one from India in SEARO, and then other from Europe and China. But there's so many countries in different regions are interested in them, and then started different sides of the pilot and implementation. And I'm looking forward to hear the more experience after this conversation from India, Nepal, Sri Lanka, and Indonesia today. So overall, what we learned is healthcare workers across member states show great interest and commitment to engage with ICOPE. Everybody said, oh, this ICOPE approach is great. And they understand, as a health and care workers, listening to the older person's concerns and then challenges, they understand this is important. And then from the pilot countries, there are a lot of positive feedback from older people. Oh, for the first time, my voice has been heard. I was not sure I can complain about my mobility loss. I was not sure because a doctor is so busy taking care of my diabetes, my hypertension. I was not sure if I can talk about different things. But for the first time, comprehensively, somebody listened to me, what my health and the well-being concern is. So it means the older person's engagement has been to be crucial across all steps of the ICOPE care pathway. And through the different pilot studies and implementation, we learned that ICOPE is feasible and adaptable to implement, including in different contexts and resource settings. But this is critical to do the local co-design. As WHO in headquarters, we provide a global guidance, and the SEARO office will provide the regional context, the guidance. But in the end, in the country or in the community, it's really important to adapt and localize in your context. That is a critical point. And then lastly, multi-stakeholder engagement and partnership facilitate implementation. You do not need to do it by yourself on your own. ICOPE requires multi-stakeholders that speak to the mindset of the decade of healthy aging. This is really important to include local and national government, civil societies, academia, communities that include town hall, post office, community leaders, and the religious leaders. These are the people who know where older persons are and who know how to engage older persons. And of course, there are issues and the challenges we face. This is new. When you do some new things, there is a challenges but we can learn and we can change and we can transform. As I said, human resources is identified as the main barrier to ICOPE implementation, including lack of skills and training. So we will hear more about how in SEARO region ICOPE training has been done, and then how to build the capacity building. And second is financing. Health economic assessment still needs to be done comprehensively, including reimbursement for staff time linked to the universal health coverage. Because ICOPE intervention is more towards the prevention and promotion, not many countries have included under UHC interventions. Use of digital technologies, we have learned this is a lot of advantage through the COVID-19. But at the same time, it can be barriers, issues of access, interoperability, integrity, data governance, and usability that needs to be addressed. Lack of coordination and collaboration within and between health and social care systems and service provider can be a barrier. But at the same time, I was told often, ICOPE is for the first time to bring different stakeholders. So this is the last slide, how as WHO headquarters support for countries, we support to develop the policy and program action plan for healthy aging, because not many people, not many countries have already established the policy and program, or they may define the existing guidelines, the existing program. So this is an example in Mauritius, they developed the ICOPE strategic and action plan renewed in 2022. And we also provide capacity building for health and care workers at the primary health care in different countries. When we do the capacity building, is most important thing is how to adapt care pathway in the local settings. We learn from the participants how to localize these care pathways. Thank you very much for your attention.
Thank you so much, Dr. Yuka. So I would ask my participant to listen to 2 more presentations, and then we have a Q&A before we go to the country levels of presentation. The next presenter would be Dr. Nina Reiner, the Director of Family Health, Gender and Life Course Approach to WHO Southeast Asia region. She has 25 years of experiences working in these areas of work. You're going to be hearing about the progress and challenges in Southeast Asia region in implementing the ICOPE. Dr. Nina Reiner, the floor is yours. You may turn on your camera as well.
Thank you very much, Dr. Suvaji. Although I have been in WHO for 25 years, but I started my career in 1980. So having worked for 42 years in public health with a particular focus on maternal and child health, I like to say that I'm not an expert in aging, but over a period of last 7 years that I've been managing aging program before Dr. Amrita joined us, and Dr. Suvaji in my team supported me with age-friendly cities and communities, and she in the morning co-chaired a session. I'd like to share with you the progress related to healthy aging in Southeast Asia region and what have been the challenges. So in 2017, there was only 9.8%, which is 186 million older people in our region. And 2030, by the time we finish our SDGs, it will be 289 million. And 2050, it will be almost 500 million. 500 million population will be older people, which in a way is a good news because the longevity is increasing, the quality of life is increasing, people are getting better, but is our health system and our social welfare systems and our families and communities ready for this kind of rapid increase in the population of older people? So there is a variation in the region. Sri Lanka and Thailand already have around 15%. In 2017, they had 15%. Although regional average you can see is 9.8, but Sri Lanka and Thailand had 15% of our population above 60 years of age. If you see, I don't want you to tax your eyes. It's increasing globally, and you can see country-wise variation. And you can see that in many countries, the number of people 60 years and older have increased, have already overtaken the number of children. By 2015, more than 1 in 5 people will be over 60 years of age, double what that figure is today. And as we saw that 2017, there were 86 million, but against a global estimate of 962 million, almost a billion. And by 2050, the number of older people are expected to rise more than 2 billion, which will include 20% of our population at the regional level. So it's around 20% at the regional level, and you can see it's 21% at the global level. So it's a rapidly increasing, and you see this increase happening across all countries of our region, which have been listed here: Bangladesh, Bhutan, Libya, Korea, India, Indonesia, Maldives, Myanmar, Nepal, Sri Lanka, Thailand, Timor-Leste. So if we see that healthy life expectancy is a bonus if older people are in good health, and you can see that in 2010, across all these countries of our region, the healthy life expectancy at the age of 60 years was different, but it has increased, has not much increased in the past decade in Thailand, because they already had 17.9 as a percentage. And with these shifts come health, social, economic challenges. And I think this new aging population opportunities that the UN Decade of Healthy Aging launched just a few years back, very much highlighted older people who are experiencing good health and well-being are an important asset to all countries, especially socially, culturally, and economically. So it's an asset. I think that because of the healthy life expectancy, we shouldn't be worried. As countries, we shouldn't be worried that the numbers are increasing. I think it's the healthy life expectancy which matters the most. The initiatives have, these are just milestones, and I'm sure the organizers will be sharing our slides with all of you. Please feel free to use these slides in your presentation by acknowledging WHO. We have no issue with that. You can see the starting from 2012 Yogyakarta Declaration on Aging and Health. It was a ministerial conference which declared about to focus on healthy aging. And then there was a regional strategy in 2013, which was revised in 2018. We started as a region, we started working on integrated care of older people, ICOPE, in 2019. So it's 4 years. Whatever you'll be hearing from countries is a very short experience. This is an approach which started recently. And the regional expert panel, which I mentioned during my opening remarks, has really been very, very helpful and an important step. This is the regional strategy, which was developed in 2018. Although it's only until 2022, we are in the process of revising this strategy with the few recent evidences and the changes. This decade of healthy aging, I think, has clearly brought us to one conclusion that health sector cannot go alone. We need health sector, and we need whole of government approach, whole of society approach, academia, media, UN agencies, private sector, all the sectors need to be involved to promote healthy aging. And I think it has an impact in the 21st century, which will have long-lasting impact in the future generations. When our children will become older, I think our systems will be ready across all sectors to provide necessary support. So the 4 action areas of Decade of Healthy Aging are focusing on changing how we think, feel, and act towards age and aging, which is focusing a lot more on ageism. Ensure communities foster the abilities of older people. Delivering the third component is ICOPE, which is the major role of health sector. And the last is provide access to long-term care for older people who need it. Again, I think our communities and the systems need to be ready. And this is the expert panel. You can see many people, many faces may already be there. And here you see Jane Barrett, Dr. Vin Mathur is there, and many more people, I think, are part of this expert panel meeting, which we had virtually in 2021, August. So there's a process evaluation of UN Decade of Healthy Aging, which has been done globally. And across 9 countries, across all the countries of our region, these are the indicators. I don't want you to be taxing your eyes. This is the data which is going to be released soon. But the previous 2 surveys, I'll just show you the snapshots in terms of the readiness. And I think when we talk of healthy aging, the indicators for readiness and implementation are extremely important to focus on. If you see countries having a national focal point on aging and health in the Ministry of Health, you see that there has been a very good progress in 2018. Almost all the countries except 2 did not have. And by 2020, we have only 1 country reported not having, but 2022 survey, where the results are coming, country-wise results are yet to be released. We are likely to see a progress. Countries having a national strategy, and I think 2020, you see almost all the countries of our region have a national strategy or policy or a plan on aging and health. So there are many indicators, but I'm just, for the sake of the time, I'm only focusing on these 2 slides. But in case any one of you are interested, we can share the report. Countries in the region having national multi-stakeholder forum or committees on aging and health. And you can see lots of oranges and very few greens. And that's where we need to really work and support. The next one is on national legislation and enforcement strategies against age-based discrimination. And that's where, again, I think we see that there are a lot of no's and very little yes. So I think that's another area when we talk of healthy aging. It's a comprehensive multi-sector approach, and we need to really see whether these policies and legislations also are in place or not, because these have an indirect impact on health. So I think evolution of care of older people has happened over a period of time. When we started off with geriatrics or healthcare of older population, and especially starting in the second half of the 20th century. Initially, we aimed at community rehabilitation of institutions, residents through assessment intervention. And geriatrics remained ill-defined between internal medicine and nursing home care. But it's very recently that WHO has advocated a paradigm shift, which Dr. Yuka mentioned in her presentation, in principle of health in old age, by proposing functional ability as outcome of all interventions, which depend on intrinsic capacity of each individual. How the functional ability gets impacted, and functional ability doesn't get only impacted by the health conditions, but many other emotional, social, psychological support system can also impact your functional ability. So I think that's a big shift, and which we need to really welcome. Next, please. And looking at this paradigm shift, which started. So looking at this paradigm shift, when we started talking of ICOPE approach, the person-centered care, we had our regional meeting on ICOPE in Southeast Asia region in September 2019. You can see many of those who are present here can identify themselves in this picture. And the focus was really to introduce ICOPE to the member states. And these are the representatives from the ministries of health of our member states. And I think that was a very good starting point. And also we talked about long-term care through WHO integrated continuum of long-term care. It was also talked, because that's another area which is not well developed in our part of the world. Next, please. We started off a physician manual, and you can say that experts were identified and the draft was developed on when you want to talk of ICOPE as an approach and you want to train primary care physicians, what should be the content and what should be the training methodology. So that's an expert group we constituted who worked on the physician manual. And you can see of these, Dr. Prasun, Dr. Ramesh Kandal, Dr. Arvind Mathur, they are here already with you. So I think that's something which was a starting point, and we developed a manual for a primary care physician, which has it's a training package, which has a participant manual and a trainer's manual. So both these packages are now available in hard copy, and they are on website and also in the digital form. So we thought there's no point of only focusing on primary care physician unless you bring in the most important part of health system, which is our nurses. So we developed the nurses manual training package. The nurses training package was also developed in consultation with some from across our different countries of our region. We got the experts to come and review and see how nurses can be trained in ICOPE approach. So this training package is also already available. And so these are the outcomes in the last less than 4 years. We have been able to develop a training package for frontline health workers, training package for long-term care, training package on ICOPE for nurses, training package on ICOPE for primary care physician. And this is the link we have given. So these are available in print as well as digital. Digital physician has been physician one, nurses one is almost finalized with videos and role plays and audio PowerPoint presentations, and frontline health worker one is still going on. So, okay, yes, I think while we were developing these packages, something which came to our mind, which is very important for all of us to focus on and pay attention to, is the health workforce needs to adapt and, the changing needs of the older people. We see that most of our health services are geared towards maternal, newborn, child, adolescent health and disease oriented, and especially now the focus has come on NCD. And even today, many people think that NCD is older population, but that's not the case, because older people need much more than NCD management, which is hypertension, diabetes, heart disease, and so on. But they need much more support from the health system. So with the changing needs of the populations, as I said, this population is growing, we also need to focus on the health workforce development. And this is what skills do they need, the new roles, additional numbers, mixing, deployment, all these things we need to really focus on. Otherwise, ICOPE will remain a dream. So summary, I would say that we have most of the countries are in agreement for adoption of ICOPE in the health system. Clinical demonstration of ICOPE in primary care simulation setting, is something which has been done. This package which we developed were validated in Pune, India, Bhutan. This app is something which we are now finalizing. And there are a few member states you'll hear today about their experience are also adapting and taking it forward. So far, we have trained 135 master trainers for primary care physicians across all countries of our region. And we also have a state of long-term care in the region, which is available. It's a document which is there on our website. And the state of long-term care is not any better. I think that's something which really needs a lot of focus on. And we can't have ICOPE, as Dr. Yuka also mentioned, if our backup system for home-based or institution-based long-term care is not strengthened, because there'll be few older people who will be requiring it. I think the going was very good unless we had, COVID. And COVID has really pushed back many of the, work which was being done. But the blessing in disguise is that during COVID, because it impacted in terms of infection and death, it impacted older people much more. So, the focus on older population has come in a big way. So the mental and health well-being, essential health services got disrupted, economic activities were jeopardized, ageism, discrimination, stigma, all these happened during COVID. And I think I don't want to elaborate upon it because most of you are quite aware of it. And I think the vaccination, the service delivery, and vaccination and the coverage with interventions was very, very useful. But then we understood that if you use digital health or telemedicine, older people, because of their lack of capacity to be able to handle even mobile phones, was very limited. So how family support system came in. So all the stories, all of you are quite well aware of it. So what's in conclusion, I'll say we have made good progress related to ICOPE in the region. We are having opportunities to advocate for ICOPE as part of the universal health coverage, as also part of essential service package. Use of digital technology is important to really scale up the capacity of the health workforce. We can't start every program with the training and end with the training. And if we imagine in a country like India, in a country like Indonesia, Bangladesh, if we have to train all the primary care physicians, nurses in ICOPE, how many years will it take? So I think we have to really think of innovative approaches to build capacity and to sensitize and orient our health workforce. So I think long-term care is in the phase of evolution, and substantial work is required for improving the long-term care in our region. So I would say let's invest in older people to add life to the years we are giving now. As you see, the longevity is increasing, but time has come for us to really focus on the quality of life which we give. If I ask any one of you, everybody would like to live longer, but live longer, in a healthy way. So I wish this forum productive deliberations and look forward to our onward journey together to achieve the future we want for present and coming generations. And to effectively confront this challenge, we must remain agile, adaptive, sharing knowledge and lessons learned on how best we can ensure all older people can be and do what they value today, tomorrow, and for many generations to come. I once again thank IFA for convening this event, which is exactly the kind of engagement that the decade of healthy aging envisioned. Thank you very much. Over to you, Dr. Subaji. I apologize if I've taken a little longer than expected. I know we still have a bit of a buffer in terms of time. So I thought for setting the stage, we can really go a bit longer to share our original experience and progress. Thank you. Over to you, Dr. Subaji.
Thank you so much, Dr. Nina. And I know that if you are here, you're going to be so animated, and also everybody will have good interaction with you, a lot to share indeed. The next presenters would be Professor Erwin Matu. You have seen his picture before in those slides. He has he is a director and managing trustee of Asian Culture for Medical Education, Research Innovation, and chairperson of Caregiver of Asha Society as well. He's coordinated WHO Southeast Asia, the Indian Academy for Geriatric Care, and ICOPE training before. So without much further ado, the floor is your, Professor.
Thank you. Thank you very much, Dr. Subaji. At the outset, I thank WHO and IFA to give the opportunity to share our experience of conducting the training of trainers from Southeast Asia region on ICOPE. So we have already been primed about decade of and importance of ICOPE integrated care, and we have seen that. So I'll come to the important thing that WHO SEARO supported the Indian Academy of Geriatrics for conducting training for the master trainers from the Southeast Asia region. Indian Academy of Geriatrics is a professional body with almost 1,000 physicians being the member of that academy. which is primarily involved in training and educating the healthcare professionals about the old age care. So once we were given this particular task, we coordinated with and partnered with our sister associations from other countries, Bangladesh Association for the Aged and Institute of Genetic Medicine, Sri Lankan Association of Genetic Medicine, Genetic Society of Nepal, Indonesian Genetic Association, Mahidol University, Thailand, and NGOs like HelpAge, Jan Seva Foundation, various medical colleges and hospitals, and from India. And we had facilitators from all the countries besides India, Thailand, Sri Lanka, Myanmar, and Nepal. So for this particular training, since the COVID time was going on, we felt that this training has to be conducted on online mode. And for this, we started preparing for this by deciding upon the platform, building a platform for sharing the resources and communication also. And we started planning for this particular training, and this was conducted between 21st October to end of the November 2021. And we had 5 sessions during this time of 3 days each. And in these sessions, around 16 to 39 participants were there in these sessions. And the sessions were of 5 hours a day for almost continuously for 3 days, with almost 24-hour sessions in total, where we included both case-based studies also and practical demonstrations. And the format was that there would be a 15 to 20 minutes of presentation followed by discussion. And this was also then evaluated by pre and post test also. So in all, we received 188 applications for the training, out of which 136 could participate. They were all doctors with MBBS, and many of them were postgraduates. Those who couldn't attend, it was because of their job working hours, or they had internet availability issues also. And when we look at the participants, there were 85 from India, 21 from Indonesia, 14 from Thailand, 8 from Nepal, 6 from Sri Lanka, and Bangladesh, we had 2 participants. And this was a very, I would say, a great experience for us to connect with our colleagues across the Southeast Asia region and try to understand about the ICOPE itself. And also, it helped us in communicating for the other aging issues with those participants. And the training content involved to provide the common overview of common problems which we encounter in the old age, and with a ICOPE approach. And the feedback which we received from the participants was quite encouraging. Most of them felt that they had a satisfaction with the kind of training they received. It upgraded their knowledge and skill. The instructors, they found they were effective with good, clear, organized presentations. And they were also happy about the interactions which were there. What advantage we found out of the online training was, but because of in offline training, the communication and connectivity is less. So herein, we could connect with large number of participants with no constraint of time, space, and resources. And it also provided a flexible accessibility to all across the region on the similar time, basically. And since it was in a continuous online training, so there was a synchronous interactivity also, and feedback was also there, and it definitely proved to be a cost-effective region. So this particular kind of training is challenges, because there are technical issues of poor computing skills or internet connectivity. Few participants felt that the authentic patient experience can only be had by an offline connection. And interactivity depended upon the participants' ability to communicate during the online training. So there was this particular thing was also found, was considered as a challenge. The suggestions which we received from the trainees and the facilitators were that they felt that we should include more video presentations, for which, as Dr. Raina mentioned, that they are already preparing those videos. And we should have more disease-oriented lectures, case discussions, or they felt that instead of 3 days of 5 hours each day, few of them felt that it could be spread over 7 to 8 days with 2 hours each day. And there was some language barrier which was reported by participants also. Of course, the pre and post test showed that we had achieved our goal of passing on the knowledge. The follow-up which we had with our participants has been encouraging. Most of them, after a year when we contacted again, they felt that it has their practice. They have incorporated, most of them have incorporated ICOPE in their clinical practice. Many of them have started training, and few of them have been able to advocate ICOPE for the policymakers in their countries. So that has been heartening for us. So, dear friends, I'll just conclude with this, that the online training has, by Southeast Asia region, WHO SEARO supported IAG ICOPE training was successful in connecting with physicians across the region. It has definitely changed their skills and knowledge, and it has also translated into further training in their. Hope this is going to be useful for the further propagation and implementation of ICOPE. Thank you. Thank you very much.
Thank you so much, Professor. So this is the first 3 set of presentation, and I think it would be nice for us to even interact a little bit, just maybe a few questions from the floor before we go to the country presentations. Any burning questions for the 3 presenters that you want to ask? Anyone of you? Maybe from other region, and you might want to learn what happened.
Thank you. I'm Shi Tiqiu from Taiwan. We integrate ICOPE into our annual health checkup for older persons. We include those items. And you know that we have been promoting health-promoting hospitals for decades. So it's important that not only we learn, we should pay attention to these items, but also we try to do interventions for prevention, but also for improvement. So we need a whole clinical pathway. And it would be important if the hospitals or even the accreditation can include the documentation of the status of these items into the accreditation to make sure that this would be done for everyone regularly. In addition, I would like to say that as many of you have been working in the communities, you know about their mobility, their nutrition, these things, the resources are in the communities. We look at the status, but we want to improve it or to promote it. But the patient then go back to where he or she lives, and the resources are there. So we need to have a resource list. And in addition, if the physicians are very busy, sometimes for some items, I'm hoping they can be designed to be done for self review. So the patient can fill in the forms.
The self-assessment kind.
So then the older persons are engaged, and they are part of it, and they can work with the clinical team as the partners. Yeah, thank you.
Thank you very much. That's also suggestions for the active aging. I think it's a comment, and I very well, thought of. We worked together before on the hospital accreditations and health promoting hospitals. So I think that's a very good approach to make sure that every hospitals have that kind of guidance and manual. So I will take that as a suggestion. Any other questions? Yes, can you introduce yourself as well?
Sure.
And one more.
Hi, I'm Caitlin Littleton from HelpAge International. I'm putting together, it's nice to see you, Dr. Raina. I don't know if you can see me. I was thinking about Yuka's presentation, which has the big conceptual framework of where WHO is trying to go. And we know it involves going beyond what the health system is doing, beyond WHO, beyond Ministry of Health, to that multi-sectoral collaboration, at least in the screening and in the pathways. And I know some of you are piloting community-based approaches to this, but I'm wondering how you're finding it at a regional level when you think across your grid of ICOPE progress. How much are you seeing engagement with other ministries and with other sectors, civil society, private or otherwise?
Okay. All right, I think I'd give the floor back to Dr. Nina or Yuka. Would you like to respond to the last one from HelpAge?
Yeah, thank you. Very pleased to see you, Dr. Caitlin. I think we were exchanging emails, and I really was very keen that you come and participate. I think one ICOPE, as you see, is focused on healthcare workforce. And as WHO, our focus is on building capacities in the health system and focus on health sector. We have a wonderful example where we involved all the geriatric societies and professional associations on aging across our member states. And Dr. Arvind Mathur led it, and he was able to pull together different professional associations and train these healthcare, primary care physicians as master trainers, where his presentation clearly highlighted that. Civil societies, INGOs, NGOs have a very, very important role to play. And as was mentioned by one of our participants from Thailand, that they have incorporated it into the annual checkup as well. So we should not really, and we would need civil society engagement and other sector engagement because ICOPE, the different components can be practiced by different people. And as our Thai participant very eloquently highlighted, and I'm very impressed, she needs a round of applause, saying that they have picked up few portions and they have put it in their annual checkup. Similarly, some assessments can be self-assessments as well, and it will depend on how you want to really take it forward. But the linkages, we shouldn't really leave it at self-assessment, but the linkages with the management or the health system across all levels of health system is extremely important. To be truthful, most of our countries are at a nascent stage where they're in the process of adapting these packages. So health sector for ICOPE as such, health sector is working, but then how do we link it to the other sectors like for assistive technologies or for social support or for nutrition support? Other sectors are extremely important, and Dr. Yuka's presentation highlighted that. So I would say we have just started working on it, and we have started to first build a pool of trainers who can really give this training, and we are trying to see if digital web-based trainings or app-based trainings can also help expand this whole approach and change the mindset of our healthcare workforce, the doctors and the nurses and the frontline health workers, so that they should know anyone who is walking into their clinic is not 6, is not 36, but is 63, how do we manage? How do we assess? It's a very different approach than what they have been managing till now. So we are at it.
Yeah.
And we'll need help-age collaboration in a big way. Over to you, Dr. Subhaj.
Thank you so much, Dr. Nina, and maybe we can hear more from the country. Can we wait for the country presentation, and maybe we can collect that later? Sorry to interrupt because the time is pressing on us. We have the very great presenters from India. So we have the three persons. The first one will be from Professor Prasan. He's also the TAC member, the Technical Advisory Group of WHO Southeast Asia. He's from the India Institute of Medical Science from New Delhi, and Collaborating Center for Healthy Aging at the AIMS. So you have a lot of experience, and please share with us the India experience. Professor.
Thank you, Subhajit. First of all, I'd like to thank WHO, SEARO, and IFA for giving me this opportunity to share my experience in my institute. As already my previous speaker, Dr. Yuka and Professor Dr. Raina mentioned that, so we try to see how tertiary care center we can try ICOPE. Previously, as a geriatrician, we used to do comprehensive geriatric assessment, but as you know, who are doctor here, detailed comprehensive geriatric assessment for elderly people is not so easy in quick clinical practice, where we see every day almost 200 patients in our clinic. So definitely ICOPE has helped us to quickly screen the usual geriatric syndrome like fall, frailty, dementia, depression, and also then we can quickly have a triage-like system, and then we go for detailed assessment as and when needed. So we try to see, the objective was to see the feasibility of WHO ICOPE approach in tertiary health centers and to see the impact, its impact and their overall quality of life and well-being index, because nowadays we are talking more of well-being index. It is shorter version also, so we used WHO 5 well-being index. So the methodology was during the first visit, we used to say do a quick ICOPE screening. Then as and when needed, we go for, as per the protocol, when there is a deficiency in any one out of the 5 domain, we see cognition, your anxiety or mood, then mobility, then vitality, like nutrition. So any of the domain, and of course vision, hearing. So any of the domain you have problem, then we go for detailed assessment. Then we see we did WHO 5 well-being score. BADL is for, that is activity of daily living. Those who are non-medical, I'm telling for them. Here we see basic activity, balancing, transferring, eating, bathing, toileting, like that. Then instrumental activity is little finer movement, finer activity. Then frail is one quick screening scale to assess frailty in elderly people. SARC-F is also for that, and polypharmacy. Polypharmacy, more than 5 drugs in elderly is polypharmacy. Then CCI is Charlson's comorbidity index. It is to understand the other comorbidity, because no elderly people are without any comorbidity. And socioeconomic scale by Kupuswamy scale, what we practice in India. So then personalized care planned by treating physician once they have, other than usual writing prescription for hypertension, diabetes, coronary artery disease, we just quickly screen the through ICOPE any other problem they have. We have a dedicated team of dietitian, psychologists, physiotherapists. So we have that opportunity to give the customized care plan. And then second visit, again, we did the same as a repetition to see what are the changes, and feasibility assessment by 9 parameters, and of course, impact by WHO 5 well-being score. So it was cohort study follow-up for 6 months only, because just we wanted to see the feasibility. It was between 2021 to 2022. We made this as our project thesis proposal for a MD student. So sample size was 100 with a dropout of nearly 30%. We we thought it will have dropout. So it was in Geriatric Medicine AIMS, New Delhi. That is the premier institute of India. And we have inclusion, of course, 60 plus consent, and currently living in Delhi NCR region because it's easy to follow up. Otherwise, we get patients across the country, but we only included people who were from Delhi NCR, that is the national capital. Yeah. So result is like mean age was 69. Of course, male was gender dominant because still in our country, male people comes to hospital more as compared to female. Then from lower economic, nearing 43% people are from lower economic status. Intact activity of daily living was 99%. That is a good thing because so that only they come directly to hospital in OPD setting, because this is not an emergency setting or acute deal patient. These are healthy, chronic, comparatively healthy, chronic patient, you can say. Ideal intact was 62%. They had Charleston's comorbidity I have mentioned. Polypharmacy, 42% people has polypharmacy, which is very, very common. You know, we see sometimes more, which is not a great things, but yes, they visit multiple doctor and get multiple prescription and just add them. Similarly, 6% had sarcopenia, frailty was 19%. And there was no domain impairment. Domain here means, as I mentioned, the 6 domains of intrinsic capacity. So in baseline, you can see this is the domain I was mentioning. Visual capacity impairment was 30%, cognitive capacity was 17%, which is more than expected actually, and it's actually alarming because cognition is the most important domain of intrinsic capacity we should assess. Then psychological capacity, that is impaired mood, you can say depression or low mood, 20%, hearing impairment 10%, vitality is like nutrition, we assess by nutrition 8%, and locomotor capacity was there in 15%. Locomotor impairment means like osteoarthritis knee or previous stroke or Parkinsonism, neurological or peripheral causes. So this was the initial domain impairment. So at least one domain of intrinsic capacity was impaired in 89% of the people who are coming to OPD. So those who have not started practice, if you can incorporate in your OPD, you will see the result. So this was the result I have mentioned, cognition. So when we did the follow-up of 107 patient, cognition was like there is no change of cognition, because you don't expect if someone had cognitive impairment, it will change within 6 months, because you know it takes a lot of time. Then psychological capacity, but of course psychological capacity with medication and also counseling, it improved significantly. Locomotor capacity improved with good physiotherapy or giving an aid or surgery, whatever was needed, because it is a tertiary care center. We could able to do everything possible for the patient. But important is to picking them early and doing the intervention. Similarly, in nutritional status, we had significant hearing capacity. We could able to promote hearing aid and to make them compliant, which is very, very difficult for elderly people, you know, because in follow-up, though it is 6-month follow-up, but it is a really, really encouraging result, and it is under publication now. So visual capacity, again, we rectified immediately with mostly it was cataract, so we could able to do that. And WHO Wellbeing Index also, you can see there is a significant improvement with improving intrinsic capacity. So this is the same WHO well-being score. And then because you know even you can customize as per your country permission to do the scale, assessment scale, like we did CDR and PHQ-9, MNA and CDR we practice in our OPD settings also. We have a dedicated memory clinic. So except cognition, every domain there was improvement, you can see. So this is first study from India to see the feasibility in tertiary care center, and being AIMS, if we can publish it and promote it through ministry, we believe that many other institutes will start follow. And I have already interaction with Dr. Raina about can we implement in many other medical colleges also, engaging ministry. So it is definitely feasible. It is not only feasible, I can say it is a practical things. I'll come to that point. And positive intrinsic capacity rate comparison to INSPIRE study is 89%, and in-depth assessment of impaired domain compared to we did that as compared. So it is so we can see it is highly prevalent impairment in intrinsic capacity those who are coming to your OPD. ICOPE approach is feasible, and personalized care plan can improve intrinsic capacity as well as overall well-being of elderly people. So this is after this encouraging result, I could able to convince my director to start a ICOPE clinic. So we have started this in AIMS. Now I have database of more than 1,000 people, we have dedicated to 2 nursing staff for initial quick assessment. And as you mentioned immediately, we have also published a self-assessment tool, which is ICT brief. You can get it in net. ICT brief tool, what we assess 30 questionnaire, and then we prioritize from there, directly go to ICOPE, then followed by detailed assessment, and like that. And yeah, I'm done. And this is our National Center for Aging, which is going to be inaugurated. The OPD has been started. We have a dedicated comprehensive geriatric care center for 200 people along with research center. And I'd like to welcome all of you. We are conducting a national event, GeriCon 2023 in September, where we will have multi-ministerial engagement, what Kathleen just immediately asked. I'm trying to engage Ministry of Health, Ministry of Social Justice, of course, WHO SEARO, WHO country office, for both ICOPE training of primary care physician, as well as we will have a national consultative meeting on decade of healthy aging, where ICOPE will have a major role to play. And of course, my acknowledgement to my team in AIMS, Dr. Parul thesis, which we are going to publish, Dr. Avinash, my colleague, and others colleague I can name, and WHO headquarter, SEARO and IFA. And this is my book, which has been published in 2019. But there also I have explained ICOPE, not ICOPE, intrinsic capacity that time. And I was lucky to, offer my book to Aislini, who started this even before Dr. Yuka. But unfortunately, she is no more. Thank you. Thanks for listening.
Thank you so much, Dr. You made a very good, but it is also important to hear other colleagues from India. We have Dr. Shanti, who also from the College of Madras. She was a National Center of National Center of Aging and many experience. The floor is your ma'am.
Thank you. Thank you for the introduction. First of all, I thank the WHO and the IFA for having given us the opportunity and platform to share our experience on this training of frontline health workers at our tertiary care institution at Chennai in India. So, looking at the status of Indian older people, we know that population aging is very exponential, and it is expected to intensify and reach 13.1% in 2030. And not only that, the age dependency is around 62 per 100 working age population as per the last study. And we all know that chronic non-communicable diseases and their complications result in multimorbidity. But more than that, we find there is a decline in the intrinsic capacity and functional ability in addition to the chronic diseases. To forget about the geriatric syndromes, which are complex medical conditions, which are multifactorial in origin and also difficult to treat, and they end up in long-term care. So in long-term care means apart from medications, we need teamwork with good nursing care, physiotherapy, and caregiver support for it to have an effective care for the elderly, needy elderly. And not only, we find that the assistance for at least one ADL, it is 9% in women and 6% in men. So the healthcare system has to be geared up for effective screening and management of the problems of the older people. And for this, various healthcare professionals involved in geriatric care, they have to be sensitized and trained for early and appropriate assessment and deliver comprehensive care for the elderly. A few words about our institute. It is Madras Medical College, a premier institution at Chennai, established the first geriatric medicine department in India way back in 1978, and it is pioneered in geriatric care. And the department, which was upgraded as Regional Geriatric Center in 2012, now converted as a National Center for Aging, yet to start its clinical work. And here we focus on the clinical care of older persons above 60 years of age, and apart from that, training and teaching of postgraduate students and involved in research activities. And in coalition with the other programs organized by the Government of India, like the National Program of Healthcare of Elderly, and the NGOs in geriatric care but in particular HelpAge India, we train the medical officers and nurses, physiotherapists and caregivers in a periodical manner. So this was a training program of NPHC with the WHO support. This was in 2018. It was a training of trainers program conducted at our institution to improve the geriatric care in India. It was ably supported by WHO and our state government, and so we could successfully train the nurses. So coming to the ICOPE, functional autonomy is the aim of geriatric care as the textbooks describe, and nothing but combination of intrinsic capacity and functional ability as well defined by the ICOPE tools. So the ICOPE tools for intrinsic capacity are the 5 domains, mainly the cognition, locomotion or mobility, vitality, malnutrition, then the sensory component, visual and hearing, and of course the psychological or the mood, depressive symptoms. So here in the training for nurses, we ask them to do these tests as a screening test, like remember first narrate 3 words, ask them to remember, and then later they have to recall. In between we have to assess for the orientation of the person to time and place. And for the mobility or locomotion, do a chair rise test, rise from the chair 5 times without using arms in 14 seconds. And malnutrition, of course, unintentional weight loss of more than 3 kg in 3 months, or whether they have a loss of appetite. And if there is answer is yes, again they are further screening is important for them. And for the sensory visual loss, if the screening questionnaire is having any problem with the vision, difficulty in seeing far or reading, any presence of eye diseases, or if they have any chronic medical conditions like diabetes, hypertension, which are likely to produce retinopathies. So if, and hearing, of course, whisper test or a screening audiometry can be done, less than 35 decibels, we are supposed to refer them for further evaluation by the physicians. And depressive symptoms over the past 2 weeks, if the person is feeling down or depressed or hopeless, or if they have loss of interest or pleasure in doing things, again they are supposed to get a further evaluation. So for these if the answer is yes, if they have problem, impairment, they will refer to the primary care physician and further specialized geriatric care at a later date. So next component is the functional assessment, the ADL or the cards index. Here nurses and physiotherapists were trained. Like the 6 main domains what Prashun mentioned, these are the dressing, transferring, toileting, continence, feeding and bathing capacity. So if the person is independent, a score 1 is given. If they are dependent, 0. And total point is 6. If they have a good higher score, it means independent. And if they are having lower score, total or partial dependence of such individuals. So we trained in-service nurses training for 100 nurses in 5 batches of both the primary and secondary healthcare facilities and nurses from our own institution. Here screening of the elderly was taught to them, and when to refer to the person to the physicians, and also a person who is working, a nurse working in the geriatric department or in the tertiary care center, they have to play a role of part of the geriatric care team at the hospitals. And not only that, they have to assist the medical officer in geriatric care. And more important is the follow-up and counseling with regard to medications, nutrition, exercise, and vaccination, which they have to keep on emphasizing for the older people. For in-service physiotherapist training, 75 physiotherapists at the block level PHC in 3 batches. This we could do with the help of the state government, who actually had a vision to improve the care for the older people who are unable, who have restricted mobility, and also they have placed them after training. They have placed them in position in service so that effective implementation can be done. And here again they were assessed to do the screening test, especially the chair rise test, and if they have any difficulty to further undergo the short physical performance battery test, and if they have defective mobility, then the role of the physiotherapist is to train them with lower limb strengthening exercise, balance training, and on the whole rehabilitation. So for the formal and informal caregiver training is done periodically to sensitize the caregivers to identify the changes in the health status of the elderly and also detect any new symptoms. They should not ignore it thinking it is a part of aging. So detect the new symptoms and proper care of the sick elderly. They have to be taken immediately to the the family member, and also taken to the institution for further evaluation and management. So in the challenges in implementation, what we faced was the nurses who are trained. The geriatric assessment and care is part of their regular activity and not exclusive for the elderly. Another thing is they have less time allocation for the elderly amidst their routine schedule and less dedication towards geriatric care. And not only that, the older people are not cooperating for screening, Either they do not want to come or they are not able to, they don't want to participate in the screening program. And also it is time consuming. And the difficulties faced by the physiotherapist point of view, it is the persons find it difficult to access the center. The elderly need assistance during the session and as well as bring the patient to the physiotherapy center. And because of the comprehension difficulty due to hearing and vision and cognition decline, pose a great problem to the training these individuals and giving them some exercises. And generally older people, what we found, they have less motivation for activity as well as exercises. So, and all the more it was difficult to handle the bedridden older persons, even though the government developed the home care service. So there was a program called Makkalai Thedi Marthuvam, which was launched last year by the government of Tamil Nadu. That means reaching the medical care to the people in the society. So instead of people coming to the centers, it is the healthcare workers reach the people in their homes or in the society. So in that context, definitely the bedridden patients also will improve, will have better treatment and care. And so some healthy lifestyle were also were trained. The older persons were given certain training on yoga practices and balance training exercises which can be done at home and continued at home. And also use of assistive devices encouraged. Thank you.
Thank you so much, Dr. Shanti. You inspire me to start inspecting and assessing my own family members who are aging. And if it is that simple, I think it is feasible for many of caretakers also to do that. So may I request Professor Dr. Mahesh to share with us the experience he also from the Global Hospitals of ResearchGate and many long lists of experiences. The floor is yours.
Good afternoon to everyone. I thank everyone and organizers for allowing me to speak and address on this topic. ICOPE-based training of frontline healthcare workers, experience from India. So let's start. So ICOPE is such an interesting program started from WHO. The way we teach people of different sectors of society and educational institutions, you know, their attention, their mood gets elevated, you know, they want to learn. They're so happy when they come out of this training session. So because every sentence, every training has p-value, you know, p-value. It has a lot of multi-million importance. So when they go, even today also morning, I went to my institution and taught all these things to my regular students of our ashram. They're so happy. Oh, we will do this. We'll call all senior citizens to our home and offer tea and biscuits and teach this. So such an enthusiasm is there now. So ICOPE is a magic. So all these village people, they invoke frontline healthcare workers. Come, let us participate in ICOPE program like that. So target trainees, government sector and private sector. In government sector workers, and they are called as abbreviated social health activists and community health workers, female health assistants, male health assistants, community health medical officers. In private sectors, nursing schools, nursing students, BSc, general nurse, midwifery. So these are the group which we wanted to target. Let's see how much we covered. A period of training conducted from August 2022 to April 2023. States covered 2 in India. So total number of institutions addressed 8. Objectives of the training: to create awareness of deeper understanding of ICOPE, to enable these people to carry basic skills of evaluation of intrinsic capacity and make them to know how this is interrelated with functional capacity, to make them to facilitate geriatric care under the supervision of community health worker and community health medical officer or primary care physician. Decision to make right referral: primary care physician, orthosurgeon, neurophysician, eye surgeon, neuropsychiatrist, occupational therapist, physiotherapist, otolaryngologist, etc. Assisting in geriatric clinic, create awareness of intergenerational bonding and prevention of elderly abuse, educate elderly on mode of training: PowerPoint demonstration, LCD projectors, laptop, public address system, interactions based on discussion, question and answers, live demonstration of assessment of intrinsic capacity. type of training is a formal training, skills training, structure training, duration of training is 90 minutes to 120 minutes. It's not enough, I knew. But still we need, because people don't have time. So this is a problem. Skills trained, balance test, assessing gait speed, measurement of calf muscle circumference, vision test for assessing hearing ability, assessing mood and cognition. And so number of trainees, government sector, ASHA workers 60, government nursing schools 300, GNM and BSc students were addressed, private nursing school 350, GNM and BSc students were addressed. So feedback taken from in the form of letter of appreciation from head of the institutions. It was very, very positive. So these are ASHA workers. Big hope for the future. Now we have 2 places. They are promised to organize, like training program for ASHA workers. 1,000 ASHA workers will come in Panipat, and 1,000 ASHA workers will come in Karnataka, Bidar. The district health officer, he is a government medical officer. He has promised that we will see that they will participate and carry out this work for 1 year and as a pilot study. How it will be successful, because ASHA workers are very highly active in the villages, 8 standard, they understand everything and they will coordinate everything from ICOPE training and ICOPE screening to primary healthcare physician in the government sector. And this is district health office. These are nursing college students. Government nursing school. So this is an initiative from the Global Hospital Research Center, which I come from. And this is a spiritual organization where I'm attached to. Brahma Kumari's World Spiritual University. It gives emphasis on self-transformation through Raj Yoga meditation. And our multi-specialty hospital, which we have 22 specialties working in different fields, and spiritual dimension has been added to in this hospital, where every patient learns meditation when they are discharged from the hospital. So future plan to organize collective training program in which government sector, healthcare workers and senior citizens equally participate. To test training of senior scouts. Now I want to include scouts also. Like Scouts is a international recognized organization. Elderly care, largest NGOs who can play great role in elderly care. Thank you very much.
Thank you so much. I think, in fact, we also have Thailand, but the presenter from Thailand is not available today. We have 2 more countries from Nepal and from Sri Lanka. So we'll be hearing, sorry, Indonesia first. I'm skipping so fast. I'm conscious of the time. Professor Dr. Nina Kamalasari is the president of the National Geriatric Society of Indonesia. And also she is a medical doctor and internal medicine specialist, and with a PhD from the University of Indonesia. She is also the director of 3 universities, which is very impressive. So we're going to hear more from her, what Indonesia is doing on ICOPE. The floor is yours, ma'am.
Yeah, I am not a professor, not yet. Thank you, Dr. Sujavi. Let me share ICOPE progress and challenges in Indonesia. As you know, our elderly populations is increasing, and this year we will have almost 30 million elderly, and will become 63 million on 2045. And our unhealthy life expectancy is almost 9 years. Based on our national survey, the frailty status in community dwelling older people, robust 15%, and pre-frail 66%, and frail almost 19%. And dependency ratio of the elderly to productive age is 16%. And dementia prevalence will become over 4 million in 2050. Indonesian journey on ICOPE began with several internist geriatricians attending ICOPE online training by Indian Academy of Geriatrics, supported by WHO SEARO on the end in 2021 with Professor Arvin. Okay, and in 2022, Indonesian Geriatric Society or Pergami participate in WHO ICOPE TOT bidding, and we got the grant for doing TOT in this year. We collaborate with MOH too. Yeah. So we advocate to make the ICOPE screening as a minimum service standard as a national policy. And ICOPE Indonesian adapted curriculum with national core team, because we have to make it based on MOH standard curriculum. Next year, we do hope that ICOPE teach to all community carers and healthcare professionals on elderly services and implement it. After 8 geriatricians got the online training, we teach 36 other geriatricians nationwide, and plus 19 trainees hosted by Indonesian Geriatric Society. And we educate to 60 healthcare professionals from 30 primary healthcare services in Jakarta provinces, supported by Jakarta District Health Authority, and 35 healthcare professionals from primary healthcare services in Central Jakarta District, and 20 posyandu cadres from Bogor, West Java since February 23, and 8 from Jakarta. Our plan for ICOPE in the upcoming months, we will do online training for all Indonesian primary healthcare professionals on elderly care representatives that will be held by MOH in this July. And in August, we'll conduct TOT ICOPE for healthcare and non-healthcare workers for 3 pilot areas in Jakarta, Bandung, Bali, supported by WHO Indonesia, and conduct ICOPE screening tools validation research supported by the grant of University of Indonesia. And in September, we will evaluate our reporting system for doing implementation of the ICOPE. This is our training curriculum structure for primary healthcare staffs and for the non-healthcare worker in Posyandu or Posbindu. It involves a theory, assignment, and field practice. This one, I will show you the video for first ICOPE screening implementation in community setting in Indonesia at Posyandu Paris in West Java. Could I start the video? Do you have sound? There's no sound. Yeah, the screening doing by trained housewives as agent of change in housing complex. We call it Posyandu Cadres. Posyandu is Integrated Health Service Center in community. This time, the place is one of inhabitant house. The cadre doing the nutrition screening. Yeah, nutrition screening. Yeah, we have elderly logbook. Elderly logbook for every elderly that came to the Posyandu. But now we have to revise the book for inserting ICOPE instrument inside. Yeah, she is doing the cognitive screening, psychological screening, and put the result in the book, in the logbook. This is we add sarcopenia, frailty, and functional state screening. She is doing, she bring the barber with 5 kilograms for sarcopenia testing. This is the chair to stand test for mobility screening. Yeah. After that, we are usually we add other activities such as in this time we doing the handicraft for with kokoro paper. Next slide, maybe we have to go now. We make several videos to make the information educations well received by our cadres. So by using the free apps such as Plotagon Story from the Play Store, we make this video. This one of the video about cognitive screening. Please, make this louder, please. The sound louder.
Bu Tati, saya mau memeriksa fungsi kognitif atau daya pikir ibu ya. Boleh, Bu? Silakan, Mbak Lila.
Okay, Miss Lila.
Saya sebutkan
I
3
mentioned
kata,
3 words.
nanti
Please
tolong
repeat
Ibu
after
ulangi.
me.
Ikan,
Fish,
kursi,
chair,
sapu.
broom.
Ikan,
Fish,
kursi,
chair,
sapu.
broom.
Betul, Bu.
You are right.
Ibu ingat-ingat
Please
ya,
remember those 3
karena
words
ketiga
because
kata
I'll
tersebut
ask you again
nanti
later.
akan saya tanya lagi.
What
Bu,
is the date today?
sekarang
Say it
tanggal,
completely,
bulan,
date, month,
dan
and
tahun
year.
berapa, Bu?
May 29, 2023, Elderly National Day.
Hebat deh si
You
dia.
are great, Mom.
Aja tanya. Saya
Even
tanya
remember
lagi ya.
our Elderly National Day.
Sekarang, Ibu
I
ada
ask
di
you
mana?
again, where are you now? At Posyandu Paris, Chiangsana Village, of course. You are amazing, Mom. Now I ask you the 3 words that I mentioned before. Do you still remember? What are they? Fish? Chair? The other one is broom. Are they correct? Hooray, you are correct. Fantastic. So, because you can answer 2 questions, date and place, and you could repeat the 3 words, your cognitive screening is good. If elderly gave wrong answer in one of time and place orientation or cannot repeat the 3 words, maybe there is cognitive decline. So the elderly should be referred to primary health care for deeper assessment. Okay. Yeah. The advantages of ICOPE, intrinsic capacity screening is easy for health workers and trained cadres to use. And the flow of care is clear and directed based on the circles of the ICOPE and can be adapted to the context local regional capacity policies, and complex cases can be identified. And partnerships between the elderly, health workers, families, and communities can support the welfare of older people in their homes. But we have challenges too. We have limited human resources that competence in ICOPE, so we have to train so many people, and preparedness of referral systems in terms of cost, geriatric team availability, management support, and continuity of care. And national health insurance in Indonesia has not supported integrated geriatric team care. Integrated reporting system nationwide should be improved and include inserting the ICOPE instrument inside. And we have to strengthen our partnership with related stakeholders and monitor and supervise the implementation and the sustainability of the program. Thank you.
Thank you very much. And I'm really apologize that we are running late for this session. The next presenters will be from Nepal, Dr. Ramesh Kandel. Yes, sir, please join us and introduce yourself more.
Thank you, Dr. Subhaji. I'm Dr. Ramesh Kandel. I'm a practicing geriatrician, as well as I am been working closely with the government to formulate ICOPE-related policies and policies related to healthy aging. Thank you so much. At the outset, I would like to express my sincere gratitude to WHO SEARO, especially Dr. Reina, Dr. Amrita, and of course, Professor Dr. Arvind Mathur sir, and as well as the IFA for this opportunity. So I and myself and Dr. Urza are representing Nepal, and in a way, Nepal government as well. So there is a, as you all know, there is a famous Chinese proverb which says 1,000 miles of journey begins with a step. So today I'll be talking about the journey of translation of ICOPE from the SEARO level to the country level Nepal. So this is the trend of population composition in Nepal for between 1950 to 2050. As we see, the lower half is gradually shrinking and the upper half is gradually expanding. And as per the latest 2021 census, we have 10.1% of older population in Nepal, which has substantially increased. And I would like to say we don't, now I think we should change the name of this structure. We used to call population pyramid, but nowadays it doesn't look like a pyramid, it looks like the Buddhist stupa. So we can say population stupa. So I would like to talk about the guiding document. This is the genetic health service strategy, and I had an opportunity to draft it as a principal consultant to Ministry of Health and Population, where we have been talking about healthy aging, various components of healthy aging, as well as there are 3 objectives and 15 strategies under. So in the strategy 4.10, we are talking about training medical officers as well as staff nurses in geriatric care to support the geriatric services in federal and provincial level. This is a hard document for this. Now we can proudly say we have the national strategy, 10-year-long national strategy. So it coincides with the decade of healthy aging as well. So how I got inspired in Nepal, this was the opportunity where I was working as a consultant in WHO SEARO. So after working as WHO consultant, I went back to Nepal and I insisted the government that ICOPE should be launched in Nepal. It's the need of the hour, and there are my, all of these have been my inspiration. Professor Mathur, Professor Day, Dr. Prastun, and so many others in the room. Dr. Rena from WHO SEARO. So after that, we went to Nepal, and what I felt is unless the ownership of ICOPE is taken by the government, the implementation would be a very, very big challenge. So I insisted government to develop standing operating procedure, SOP for geriatric care. And to share with you, Nepal government has a program in which we have been running geriatric OPDs in all hospitals which are more than 50 beds. And we have been running geriatric ward as well as geriatric OPDs in all hospitals which have more than 100 beds. So this is the national document which talks about how geriatric care is conducted in every hospitals. And interestingly, we have incorporated the ICOPE in this document. So this is a compulsory SOP which has to be carried out for geriatric care in every hospitals. And we have been able to incorporate. Then we are talking about how to do ICOPE assessment in OPD and how to check the domains, and this is the hard copy. We also have in the next year, we have the ICOPE screening questionnaire, and every health person who goes through this document, who is the implementer of this geriatric program, they take it as a reference document and accordingly do the ICOPE assessments. So this is the work by Dr. Urza, where she is working. She has been quite active. She is the first lady geriatrician of Nepal. She is here. So this ICOPE was done as a part of mini CGA in our hospital, and it was found that the most important domain which was affected was locomotive domain, which was impaired in 39% of the individuals. By now, she has recruited about 107 patients in our dedicated geriatric OPD. And interestingly, this geriatric unit is under Department of Internal Medicine, where she has cleared all the conflicts between the department, and now the Department of Geriatric Medicine and Internal Medicine coexist under a single umbrella. So coexistence is always an issue. I think the clinicians appreciate it. Yeah. And another interesting thing, this is a modification of the WHO ICOPE for primary care healthcare professional. Actually, it's a hybrid model. is as a trainer, you might have experienced difficulty in extracting the healthcare workers from their site to the center, where you have to retain them for 1 or 2 weeks and give continuous training. So we went into a hybrid model, in which there will be 3 weeks of intensive theoretical knowledge training to the participants. The participants get an online access, a username and passcode, and based on that, they do a 3 weeks of reading about ICOPE, geriatric care, and so many things. And after they have finished their 3 weeks of online training, then they come to the site, to the hospital, to the training center, where they go for 6 days of on-site training. And this has been very successful and widely accepted by the trainees as well. And all these documents have been approved by Ministry of Health and Population and the National Health Training Center. So, talking about training for primary healthcare professionals, in federal level, we have trained around 130 primary healthcare professionals in ICOPE, and in the provincial level, we have trained 100 primary healthcare professionals in ICOPE, and you can see Urja smiling with a big satisfaction after training our trainees. So, these are some few of the representative photographs. And another is ICOPE for in-service training of medical officers. So you can see the chapter 2, and it was inspired by the WHO model, which was primarily developed by Dr. Arvind Mathur. So in chapter 2, we are talking about intrinsic capacity and functional status of older people. So these are the documents which have been taken ownership by government of Nepal. And for example, if we take about endocrine system, we don't talk just about managing diabetes and thyroid disorders. We talk about managing the condition with the eyes of a geriatrician, with a geriatric approach. So I feel it's a very holistic approach of caring for older people. So for talking about medical officer, this is my geriatric OPD. We have a dedicated geriatric OPD. We have trained 3 batches of medical officers. A total of 50 medical officers have been trained. Here you can see the hearing assessment, which is being done by our OPD nurse. The medical officer is talking about the other elements of ICOPE. So after always, impact analysis is very important. It's not only imparting training to the trainees. We always have to evaluate what the impact this training has made. Has it been really implemented at the grassroots? For that, I and Urza did a post-trainee assessment survey, in which we sent this online Google form to every participant who was engaged in the training. And to some sad experience, only 2/3 of the participants have been implementing ICOPE at their centers. So it would be always our wish to get it 100%, but only 2/3. That's also a big number indeed. So we asked them where they have been using ICOPE, and most of the trainees told that they have been working as trainers. They have been training their in-house staffs, in hospital and health center staffs on ICOPE. And similarly, only 28 of them have been using ICOPE for patient screening, and some research have been done. Around 12 of them have been using ICOPE in research. As we know, anything you publish in a third world country, that gets published in high index journals. So there's a big scope for research as well, utilizing the concept of ICOPE. And we also asked them what was the reason for not implementing, and they always told there's lack of time, where a single doctor has to see around 80 to 100 patients a day. How can we implement? And WHO has said ICOPE is a community-based approach. It is not made for the tertiary care centers. Tertiary care centers have to do CGA, comprehensive geriatric assessment, by the geriatrician, and ICOPE has to be done by the frontline health workers in the community. So it's really a big challenge how to implement ICOPE in the community. I think we have to think about, and where the tertiary care centers get the referred patients, we have certain deficit in certain ICOPE domains. So lack of time, lack of supporting staffs, lack of instruments, lack of spaces, these are major hindrances for implementing ICOPE. Then based on this survey, we came to a conclusion that we need a dedicated day, we might need dedicated time, dedicated staff, dedicated space as well as staff incentivization if you want to implement ICOPE at a grassroots level. Otherwise, this would be confined to your documents only. And finally, at the end of the day, what you can say is just the documents that we have prepared the training program. But whether the grassroots patients are really benefited by ICOPE or not, this should be a point of discussion. And language translation and validation needs to be done because we have been using, we have been diagnosing depression based on structured questionnaire. And there is a lot of interviewer bias in this. It depends if you want to extract depression after every individual. When I do an assessment, the patient might be depressed. When other does, the patient might not be depressed. So validation of the tool in the local language is a must. And the WHO country offices should be very serious about translation of these ICOPE documents. So with by this slide, as you are familiar, this is the birthplace of Lord Buddha. It's in Nepal, Lumini province, and I would like you all to visit this holy place where you will be getting the insights of Buddhism. With this, and thanking Dr. Urza for helping me with this presentation. Thank you so much.
Thank you so much. And one last presentation. This is exciting, and I visited company, and I would say that everybody should go. So we have Dr. Bhumini Karunarata. She's the James of the land and also the focal point for the National Aging Older Person programs and policies. The floor is your ma'am.
Good afternoon, everyone. Thank you very much for your kind introduction. I'm Dr. Bhumini Karnaratne from Ministry of Health of Sri Lanka, and I'll be talking with you about the implementation of ICOPE in Sri Lanka. So I will brief you about Sri Lankan country profile related to aging and the activities we have conducted so far to implement ICOPE in Sri Lanka and bit about way forward. So you all know that Sri Lanka is a beautiful island in the Indian Ocean, and we have around 22 million people in the country. So we have 9 provinces and 25 administrative districts. Healthcare provision in Sri Lanka is mainly by the government sector and a smaller proportion by the private sector. At the government sector, we do have healthcare institutions and healthcare services at the national level, district level, provincial level, and at the community level. So we do provide free healthcare at the point of delivery. In Sri Lanka, an older person is defined as a person aged 60 years and above. And of course, as per the census in 2012, the proportion of older persons was 12.4%, and it's estimated that it will be rising up to 16% this year and to up to 25% by 2040. Oh, I'm sorry. So like of all the older persons, right, the majority are females and residing in the rural sector. Of course, as many of the other member countries in the region, the share of the old group is rising rapidly. And we do face a lot of adverse implications due to aging, such as high prevalence of non-communicable diseases, related disabilities, increased mental health illnesses, and of course, social isolation, financial insecurity, so on and so forth. So like as a country in Sri Lanka, we believe that the only solution to confront these challenges of aging is the provision of comprehensive care through life course approach. And also I have heard during past few days several times that the most effective way of care provision, ICOPE implementation, is coupling that with primary health care. And of course, in this forum also it was highlighted repeatedly. Of course, in Sri Lanka, actually, older persons and their families seek medical assistance very frequently from their nearest primary healthcare institutions. And currently, there's a primary healthcare reform is being done in Sri Lanka with population empanelment and to achieve universal health coverage. So let me tell you a few words about our primary healthcare reform, because right, you all can see like there are two shades of, red and blue, right? Those are two clusters. And if you have to take this red one, so it has 5 shades of red actually. So these areas are built up around the primary medical care institutions where we have implemented ICOPE in the empanel population. And from these primary medical care institutions, we do refer patients to this Apex hospital, which is at the middle of this cluster area. And we do back referrals also. So we have coupled implementation of ICOPE in Sri Lanka with this primary healthcare reform. And of course, it's extended up to the community level. I hope you can hear me clearly. Okay, so we have conducted a lot of what's happening? We have conducted a lot of activities to implement ICOPE in Sri Lanka, not alone actually. I'm from Ministry of Health. We do collaborate with Ministry of Social Services, National Secretariat for Elderly, and of course, community-based organizations such as HelpAge in Sri Lanka, and also SEARO. There are a lot of organizations. I'm sorry, I don't have time to tell names, and a lot of donor agencies and academia. And of course, most importantly, are elderly clubs and older persons in the community. Because these activities you see today are collaborative activities of all of them, not only from Ministry of Health. So first, we have first we have conducted capacity building training programs for primary care physicians and nursing officers. They were trained as master trainers by the resource persons that were trained from WHO SEARO regional office. And those training was based on actually the trainer manual that was adopted to Sri Lanka as a collaborative activity between academia and Ministry of Health. So these master trainers who were trained, train their colleagues at their respective institutions on ICOPE, and all these trained primary healthcare workers conduct community level geriatric screening and personalized care plans and referrals at their community level. And also, we do conduct monitoring and evaluation at different levels to assess the implementation of these activities. So these are few pictures of our training programs. And these are the community level screening programs we have conducted. This is a picture of a temple actually in a village. So we do conduct community level screening as well, apart from the screening at primary healthcare level, institution level. And coupling with those screening programs, sometimes we conduct different programs. That is, this is one, and we conduct community level exercise programs for older persons. Of course, they enjoy it a lot. And this is a summary sheet. I think this will, inspire you all as well. We gather few information from all the primary medical care institutions where the ICOPE is implemented, about their empanel population and number they have screened, number they have referred to the Apex hospital, and most importantly, number back referred to them. So with this information, with this information, we carry out assessments, monitoring and evaluation at community level, at primary healthcare institution level, district level, provincial level, and of course at the national level by internal reviewers. So that's our monitoring and evaluation mechanism. And so let me tell you a few words about our way forward. We want to extend this ICOPE training program to all 25 districts in the country. And we want to implement this community level geriatric screening in all the empanel populations of primary medical care institutions, and conduct national level reviews by external reviewers, and also integration of formal and informal caregiver training to ICOPE training as well. Thank you. That's all about Sri Lanka.
Thank you very much, colleague. I apologize. We're spending too much time in this room, and the next session is waiting for us. I would request all the speakers to meet outside the room. And thank you very much for the online speaker, Dr. Nina and Dr. Yuka. Appreciate your presence. So we will report back to you, and we have to close now. Thank you.